Active exercise is a very important part of life for the boys, not only to maintain health and well-being, but also to develop sensory motor skills which are important for future learning. It is, however, not without risk for boys with Duchenne. Physical therapists will be able to give advice on suitable activities, which are less likely to cause injury while having a positive effect of maintaining muscle strength. Heavy exercise will break down rather than strengthen muscle, so it is recommended that boys enjoy normal age-appropriate recreational activities rather than attempt strengthening programs. Evidence from research would indicate that exercise done in the water is especially beneficial. Riding bicycles is also recommended as a non-weight-bearing form of exercise. Many adaptations to the height of the saddle and position of the pedals can prolong the boy's ability to ride his bicycle. Pedals mounted forward on the front wheel are easier to manage. Hydrotherapy, or any form of swimming, can be extremely beneficial as it provides excellent active exercise without the risk of overuse or undue fatigue. Rather than attending learn-to-swim classes with regular swimming coaches, therapists may recommend beginning lessons with a group of boys with similar abilities, or to have individual lessons with a therapist or teacher who is familiar with the condition. Water familiarization is the first aim, followed by acquisition of breath control. Games and activities are employed to achieve the therapeutic aims while still being great fun. The primary goal is to promote water safety and to achieve independent swimming as soon as possible. Older boys and young men who use a power chair full-time appreciate the time in the pool for the freedom of active movement it affords, for relaxation, and also for social interaction with friends. Contractures develop because not all muscles around a joint will weaken at the same time. And as a result of this, boys will adopt compensatory postures and ways of walking. The tendo-Achilles is often the first to tighten. Gastrocnemius and soleus muscles insert into the tendo-Achilles. The usual sports stretch against the wall is easy for most boys. Placing both hands on a wall for support, the boy stands in a step position, with the back leg, which is the leg to be stretched, kept straight. It is important that the toes point forward and are turned in a little as well. The heel is kept firmly on the floor. With the front leg bent, the boy leans towards the wall until a stretch is felt in the back of the calf. A stretch for soleus can also be done in this position, but this time both knees are bent. The leg to be stretched is still behind. The boy leans into the wall, bending the back leg, until a stretch is felt in the lower part of the calf muscle. His heels must remain on the floor. Passive self-stretches can be done on a rocker board against a wall. Positioning is extremely important. The feet should be slightly pigeon-toed to ensure that the tendo-Achilles is being stretched. Knees, of course, are straight. A self-stretch for the hamstring group can be incorporated into daily floor activities when playing or reading. Note that the knee should be absolutely straight and slightly out to the side. Another popular hamstring stretch is done by lying on the floor in a doorway or against a post. The boy moves as close to the wall as possible with his knee still slightly bent. He then straightens his knee against the wall and holds this position. Manual Achilles tendon stretches should be started very soon after diagnosis. The child lies on his back in a comfortable position. The operator cups his heel firmly in one hand and rests the sole of the foot on her forearm. She stabilizes above the knee with the other hand and exerts a downward pressure on it to keep it straight. She then pulls firmly on the heel while pushing the sole of the foot up until a stretch is felt in the calf. If resistance to the stretch is encountered, first bend the knee, then stretch the heel cord, and while maintaining the stretched position, straighten the knee. To stretch the hamstrings, the boy is again positioned comfortably on his back. The operator places the ankle of the leg to be stretched on her shoulder and stabilizes the other leg by pressing down on the knee. She also ensures that the moving leg is kept straight. She then rocks forward, using this movement to perform the stretch. Stretches for the hip flexors in the early stage are best performed with the child lying prone. The operator cups the bent knee in her hand, allowing the ankle to rest on her arm. She places her other hand firmly on the boy's bottom. She then pulls the leg up and inwards towards the other leg while exerting downward pressure on the bottom. This maneuver will also stretch the iliotibial band, which sometimes tightens in the early stage, especially when a wide base stance is adopted. When there is obvious tightening and stretching is difficult, it is often easier to perform the stretch with the child lying on his side. In this method, the operator stabilizes the pelvis with her knee and free hand. The top leg is taken back into extension, and with the knee extended, downward pressure is then exerted on the leg. Stretching the hip flexors may not be possible in prone, as boys get bigger, and an alternative position in side lying may be more comfortable. Notice how the operator stabilizes the lumbar spine with her knee. This localizes the stretch to the hip. Alternatively, the stretch can be performed with the boy lying on his back, with the opposite leg well flexed onto the abdomen to fixate the lumbar spine. Downward pressure is then exerted on the leg being stretched. Important points to remember are: to position the child so that he is well supported and comfortable. Stabilize the joints, which are not being moved. The intensity of the stretch should be submaximal and should never cause pain. If the child resists strongly, another method must be employed. The stretch should be held for at least 30 seconds and repeated 3 times. Overstretching is to be avoided, as the muscle responds by contracting further. If the boy actively resists, a lengthening contraction occurs, which may cause further damage to the muscle fibers. Standing frames provide a constant and prolonged stretch for the ankles, knees, and hips. If a regular standing time is incorporated in the daily routine, it will have positive effects on maintenance of range in these joints, as well as physiological benefits in other bodily systems. Another method to provide a sustained stretch for hips and knees is for the boy to lie prone on a wedge for a set time. Sandbags are placed on either side of the boy's pelvis to anchor him in the correct position, and another is placed on top of his bottom. In this way, the hip flexors are stretched. Weights placed over the ankles will keep his legs straight and stretch the knees. Particular attention is paid to the upper limb when the boy is no longer walking and his arms are bent most of the day. Contractures are likely to occur in the elbow flexors, forearm pronators, wrist flexors, and the long finger flexors. There will come a time when boys will find it more difficult to walk long distances. Parents will then need to consider providing a means to help regain this lost independence. Part-time use of a scooter or power wheelchair can restore mobility and assist in improving self-esteem and quality of life. When selecting from the many suitable chairs on the market, there are two important features to consider. The chair must provide good postural support and be adjustable as the child grows. The advice of a physical or occupational therapist who is both familiar with the condition and the associated seating issues should be sought. Scooters are an excellent way of providing independent mobility, especially for boys who are able to walk, but need to conserve their strength and energy. However, they are not always ideal as they don't provide adequate postural support and they do not have the tilt-in space mechanism. Parents can play a very important role in preventing the development of a scoliosis by paying attention to the way the boy sits in his chair. A headrest is essential for neck support due to muscle weakness in the front of the neck. When a chair has no headrest, boys will often adopt a forward-leaning position to protect their head. A headrest is also needed when reclining or tilting in the chair. As the muscles supporting the spine become weaker, a boy will have greater difficulty sitting up straight for long periods. The chair needs to be a snug fit so that he won't have to lean sideways to reach the armrests. This firm fit can be easily provided if the armrests are inset on horizontally adjustable brackets. They are then easily adjusted outwards as he grows. The armrests also need to be adjustable vertically so that forearm support is always maintained at the level of the bent elbow. Constant leaning down to reach the rests will lead to spinal curvature. A height-adjustable backrest with sacral pad or lumbar roll is available on many chairs. A backrest, contoured to support the normal thoracic and lumbar curves and extending to the top of the shoulder blades, is recommended. The seat needs to be deep enough to support the full length of the thigh to within 1 or 2 inches of the bend of the knee when seated. Adjustable thoracic supports will help key the boy into the correct sitting position and prevent him from leaning to the side. The control box and joystick need to be positioned directly under the dominant hand to prevent leaning forward or to the side. It is advisable to fit an electronic tilt-in space mechanism to the chair from the beginning. When tilted even a few degrees, the line of gravity no longer passes through the erect spine, protecting against the development of a scoliosis. The tilt mechanism also permits the boy to make both minor and major adjustments to posture at will, which greatly enhances his comfort.